Okay. I'd like to introduce to you Dr. Angel Rigueras. He is native from Miami, Florida, formal medical schooling training as an osteopathic physician, internship and residency training at Michigan State University in psychiatry. Physiatry.
I get that often. Podiatry or psychiatry? Both wrong ends.
His fellowship training also at Michigan State University in interventional
Physiatry.
and is a board certified in physical medicine and rehabilitation. And medical practice specializes in the treatment of neuromuscular skeletal pain. Please welcome Dr. Rigueras.
Thank you. So first of all, I want to say thank you for inviting me. I really appreciate that. And I appreciate your audience. So thank you. So a little bit about me, kind of what she went over. I'm from Miami. I trained in Michigan, both my internship, residency, and fellowship. And I'm a physiatrist, and just a moment of what that is. It's not very common. I usually tell people, they'll ask me that. They'll say psychiatry or podiatry. I said neither. I usually tell people, if you know what a physiatrist is, I'm sorry. Because usually something bad happened, right? So if someone has a massive stroke or a spinal cord injury, amputations, certain genetic diseases they're born with, or a lot of these type of severe injuries, they'll call me in. So that's why I usually tell people, I'm sorry. So I specialize in muscles, nerves, bones, and joints, and the diseases and diagnosis and treatment of them. So that's kind of what a physiatrist is. I wear two hats. One is as a rehab doctor. So a lot of times if someone has any of these injuries acutely in the hospital, they'll consult me and ask me, can you devise a rehab plan? I work with physiotherapists, as you call them in Canada, or physical therapists, as we call them in the States, occupational therapists, speech language pathologists, to devise these plans. The other hat I wear is as a physical medicine specialist, which is the part that I specialize more often now, okay? So this presentation, we're gonna go over 4 general areas. Generally in pain, not just specifically to pituitary tumors, but pain in general, to get a really good idea, because amazing enough, there's a huge misconception of what exactly pain is. And then we'll talk about specifically as it relates to acromegaly and Cushing syndrome, and then pain management. You know, internationally, there's a lot of controversy over pain management. And unfortunately, it's really hurt a lot of patients. And then options. So I want to start off with some questions here. And it seems like an obvious question. What is pain? Any ideas? I mean, we're all in pain at some point. Anyone want to throw out some answers? Discomfort. What else? What do you guys think is pain?
Riveting, shooting pain?
Riveting, shooting. Anything else? Immobility. Absolutely, emotional. So I want you to look at this picture. Is he in pain? Not the dog. The dog seems like he's about to have a... But this gentleman here, what do you think? Is he in pain? Not yet. Okay. Let's hold on to that answer. So this is my presentation is mostly for the U.S. population because I had the most immediate access to that. But it really does apply to all developed countries, both Western European, Canadian, certain parts of the South America, and the U.S. Okay, so these numbers pretty much hold up. It's one of the most common reasons, pain, that people go to the doctor. Okay, it costs a ton of money to treat pain. You lose work days, production at work, lots and lots of investment and loss of money from this. In America, a quarter of our population suffers from chronic pain. When we look at the type of incidences of diseases compared to diabetes, heart disease, and cancer, look at pain. That's huge. And that's a population of 80 million people. Specifically, when we look at patients with acromegaly, and we look at some of the most common complaints, what we find is the top half of all these complaints, look at that, they're related to pain. Carpal tunnel, arthritis, definitely headaches. And then I highlighted obstructive sleep apnea because we'll talk a little bit more about that, about how that is a huge risk factor for how we perceive pain and how we deal with pain. And we still haven't answered what pain is yet, so keep that in the back of your mind. Cushing's syndrome, very similar to acromegaly in terms of some of the symptoms when it comes to pain, but yet we find musculoskeletal pain, muscle weakness, atrophy, which can cause pain, 82% of people. We find here backaches, fractures in the back, vertebral fractures, 40 to 50%. Headaches, at least half. So part of this is I want to dispel some myths. And part of that is exactly what pain is and the controversies around pain. So we're going to talk a little bit about dispelling some of these myths and the treatment of pain as well. I love this little guy. This actually was my hamster, and I just put this here. Yeah. A few more crunches, and I'll have me some six-packs. So some standard myths. There's no standard of care to treat pain. That is absolutely false. In fact, there's an international board, the International Study of Pain, that has a cohort of many countries, European, Eastern, Western, certain African countries, South American, and North American, that put out every few years very specific recommendations when it comes to pain. The fear of addiction to pain medicines. This is something that unfortunately, globally, the media has gotten a hold of and has become a political platform. And there's a lot of misinformation about that. Patients just have to live with their pain. To me, this is a problem. Because, first of all, no one's defined to you what pain is yet. And all patients with pain have psychological issues. And they'll say, it's all in your head. Well, yeah, that's where my brain is. If my brain wasn't there, I wouldn't perceive pain. But, again, a lot of misinformation when it comes to pain and how people with pain are perceived. So, is this pain? What type of pain? What do you think? Why am I saying, why do you think this is pain and the other gentleman who was about to get bitten by the dog isn't pain? What do you think? The acute onset? Yep, I would definitely say that. What else? He's feeling it. Okay. Right, so he's experiencing it. He's reacting to it. Notice the things we're talking about. Experiencing, reacting. We're not talking about some neurologic pathway creating some sort of inflammatory response in some part in the brain that's saying, aha, you're in pain. We're talking about experience. This is pain. To me, this is pain. Look at this person. Look at their face. That's anguish. That's suffering. That's isolation. That's disconnect. People walking on this boardwalk, beautiful sunset, but yet here. You see, pain isn't just hurt. Pain, as a human being, we experience hurt by experiencing pain. Pain is psychological, emotional, intellectual, spiritual, social response to hurt. Think about that. When you can't do what you want to, you can't pick up your grandchild. You can't go out with your spouse or your significant other on a date. You can't go to the movies. You can't read this book because you're so tired, or you have such a headache, where you can't go out and enjoy the sunshine. Is that hurt or is that pain? You as a human being are experiencing something that is changing you emotionally, spiritually, socially, intellectually. A lot of my patients will go through all these different factors and all these different stages. They'll say, well, maybe this is happening to me because I did something wrong. Or maybe this is a test. Or maybe I'm not good enough. Or maybe they'll talk about how this is a challenge. Or all of a sudden they say, oh, this pain brought me to religion. I found God because of it. I've heard that also. I've many different things. We all experience hurt in our own unique way. And the reason this is so important to understand is because a pill does not change how you as an individual human being experience pain. Right? You are multifactorial. You have so many different things to you. How you think and how you think are completely different. How you view yourself and how you view the world is completely different than you. How you internalize your reasons for being are completely different than yours. And those are the things that affect to produce the experience of pain. So to treat pain, you must treat all of you. That is holistic and comprehensive approach. That's why one person alone can never do it. If you ever hear a one-man band, no matter how cool it looks, it just doesn't really sound as good as a real band. All right? So keep that in mind when we start talking about treatment options, because you have to build a team to treat pain. You need your endocrinologists. You need your neurosurgeons. You need your psychologists and psychiatrists. You need your counselors, whether it be spiritual, religious counselors, whether it be therapists, whether it be meditative counselors. We're going to talk about this, okay? But because all of you must be treated to address pain. That's why, to me, this is all of it. You see it. This is pain to me. So let's get on to a little bit of the science of this. When you look at the definition of chronic pain from the International Study of Pain, what's interesting, look at what they say. Lasted more than 6 months, generally affecting significant psychological and emotional affects and limiting a person's ability to fully function. They're not talking to you about the shooting pain that goes up to your brain processes this. They're not talking about this. Right? They're not talking about your thalamus processing this and the various parts of your spine editing. They're talking about it in part as you as a human being experiencing this hurt. Now, we typically in science like to categorize things. It makes it easier for us to have conversation. In the literature generally and traditionally, we talk about pain as being nociceptive pain, neuropathic pain, or mixed pain. As a pain specialist, I can tell you it's all mixed pain. Some is a little more neuropathic, some is a little more nociceptive or somatic. And we'll talk about what these things mean, okay? Let's start off with nociceptive pain. So let's say you're walking along and your cute little Yorkie gets in the way and you trip and sprain your ankle. Nociceptive pain, okay? It's a sprain, it's a joint, it's a fracture. It's not necessarily a nerve pain. Now, remember I told you that I feel that all pain is mixed. Why? Because if a nerve wasn't there, your brain wouldn't perceive it. And if there's an impulse through that nerve consistently telling your brain you're hurting, that nerve changes the way it perceives that information. And all of a sudden, that nerve becomes involved in the problem of perceiving pain. So it kind of becomes hypersensitive, like that old torture, they say a drop of water on the head consistently will drive you nuts. Why? Because you're constantly sensitizing that nerve. So all hurt is transmitted through nerves. So nerves are always involved. And remember that, that's important. So basically, for instance, in acromegaly, TMJ, big problem, big cause for headaches. People always think headaches are just from the space being occupied by a tumor. No. In fact, there's the International Classification of Headache Disorders, too, that was just published by the International Study of Pain. And if you count how many headaches are defined, there's almost over 400 types of headaches. Okay? And very common, and I specialize in headaches. And I'll tell you, one of the most eye-opening questions for my patients when I ask them, how many different types of headaches do you have? They go, oh, no one's ever asked me that. I said, because they always tell me it's a migraine. I said, well, how many type of headaches? Where do they start? Where do they end up? And it's amazing how many times I'll see, oh, it starts here, or very common, it starts here and shoots forward. And all of a sudden we're like, now we got something to talk about. And we start breaking down all the various components. And very common, TMJ, okay? Which is temporomandibular joint, which is your jaw joint. The other type of pain, neuropathic pain. So ever hit your funny bone? Feel it in your fingers? Not in your elbow. You don't ever grab your elbow, you grab your fingers. Why? Because nerves are like wires, they conduct electricity. And when you interrupt that flow of electricity, you feel it where that nerve ends. So this is where carpal tunnel syndrome, we know that in pituitary tumor type diseases, entrapment of nerves, pinching of nerves. You have it in your wrists, sometimes in your ankles, in various parts. Okay, so carpal tunnel syndrome, that's a type of neuropathic pain. Peripheral neuropathy, all right, when you have the numbness, pins, needle type sensation in your hands and feet. Even post-herpetic, if you've had shingles, that burning, horrible sensation. Or even sometimes I have patients who say, "Doc, just chop off my leg." I'm like, that's not going to help. You'll still feel the pain. Yeah, phantom limb pain. Okay? Mixed pain is basically the two are present. So if you sprain your ankle and all of a sudden you're like, man, I have also some numbness and tingling on the top of my foot, well, you feel the pain from the sprain, but you'll have some numbness and tingling involved because some of the nerves were involved. Okay, that's essentially what this is. Now, the measure of pain. There is no laboratory test that exists to measure how much pain you're in. Now, that's very important. Sounds like such a simple statement, but the implications are huge. I have tons of people who come to me, and I walk into the room, and I'll show you exactly what happens because it tells me, unfortunately, what's been going on in their lives. I walk into the room, open the door, and they go, "Doc, my MRI." Well, hi, how are you? Because they're so conditioned that that MRI is them. I've had many patients who have come in with fractures in their back and didn't even know they had a fracture, never felt it. So are they lying about that fracture? It's on the MRI. Yeah, I've had patients with perfect MRIs and excruciating pain. Well, if the patient with a fracture never felt pain, and obviously they're not lying about the fracture, there you can see it, is the patient with the normal MRI lying about the pain? That's right. One cannot mutually exclude the other. It's a fallacy of logic. So people think the MRI, electromyograms, X-rays, CAT scans, ultrasounds, all these things can tell you how bad your pain is. They cannot. They're a piece of the puzzle. As physicians, we specialize in how to integrate all these pieces to really understand you and your symptoms. So we do not have a laboratory test, a radiologic test, a physiologic test that shows us how much pain you're in. That's important to understand. To me, one of the best ways for me to measure your pain is how it's limiting your function. What can you not do? How do you sleep? How's your family relationships? How's your mood generally? How's your sexual life? How's your work life? These are questions I always ask, and I use certain questionnaires so I can measure that on every visit. And I see patients every month, the same patient every month because of the medications I use and some of the things we have to titrate. The weather affects this, lots of things. It's that conversation with pieces integrated into it, such as MRIs and everything else, that allow me to ascertain where the patient is in their life. But there is no laboratory test that can show us. The best we have is this thing called the visual analog scale. They're all little happy faces, 0 to 10. Tell me how the worst 10 is your worst pain. From 0 to 10, how bad is your pain right now? Why? Because it sums up your perception of your pain. Does it mean anything? No. By itself, no. Your 5 isn't my 5. But if I know you long enough, and I remember, hey, when you fractured your ankle, that was an 8, and you're coming in and saying you're at a 7 now, I have some history. I understand you now. Okay? So this is the best we have when it comes to this. So let's talk about the management of pain. And I will say we've come a very long ways. This is actually from a medieval medical tablet on the treatment of lumbago, which is back pain. It would bleed the back, as if he wasn't miserable enough. All right, so a very heavy slide. This is from the American Academy of Rheumatology, okay? And basically, when it looks at acromegaly and Cushing's disease, their recommendation when it comes to pain and the treatment of pain is basically treat it like any other. The joint pains, treat them with the same approach, which is huge. because it opens up a whole arsenal of tools that people like me can use to treat. So I kind of just highlighted this, but essentially the same protocols that we would use to treat anyone that came in with headaches or carpal tunnel syndrome or back pain, the academy in the States for rheumatology say to us, you can use this. And that's huge. Again, just another slide from, and this is their 2011 recommendations. So I want to talk about, first of all, how important pain management is. Now, it seems like a dumb, obvious point, but the problem is most people really don't put it in proper perspective. If you start having a headache, I'm just kind of picking on headaches today, but if you are, and after a week, they're not getting better, what happens? You start disengaging, right? You start doing less stuff, start moving around less, doing less activities with your body. That leads to all sorts of problems. First of all, it can lead to depression. Why? We know many, many studies showing that disengagement from social support systems lead to depression. And we know there's a very high correlation between chronic pain and depression, about 80%. It's a comorbidity. Depression in of itself reduces your threshold for pain perception. What does that mean? That means when you're depressed, you have a greater perception of pain. And what's pain? It's the experience of hurt. Right? When you're happy and elated and everything, you're jovial, you don't feel that pain as bad, do you? Because the experience of you is joyous, even though the hurt may be the same. But when you're depressed, the reserves that you have to treat the pain or to deal with the pain are less. So we know that depression can actually alter the perception of pain. So it's very important to intervene as soon as possible. People say, well, I just wait until it's so bad I can't take it anymore. And that's when I come in and see you. And I usually scold them for that. I said, no. Small fires are easier to put out than big fires. My job is hard enough. Don't give me big fires. So very important for all these reasons. Now, quick is a very relative term, okay? Because a pill, an injection, some therapy, some counseling, all by themselves or even combined, don't cut the mustard. You're not passive in this. You're not a guinea pig. So it takes a certain degree of commitment to the treatment to be able to have it work better. And sometimes I find that people are like, they're so beat up from the pain that they're using other people's, basically, their strength, right, to push them through that. And that's okay. But that decreases that turnaround time. But usually if you help them and support them enough, then they build up enough strength of will to move forward. And then all of a sudden they have that aha moment, oh, I do feel better now. Okay? So again, it's a lot more complicated because we are dealing with factors that are more than just physiologic, right? They're human. Very important. Oops. So when I mentioned a team before, first of all, you need to make sure that your physicians are on the same page. Now, most physicians, because of very busy schedules and because we're just pulled in all so many different directions, don't normally just pick up the phone and call every one of your doctors. All right. First of all, what you tell me today, the doctor I speak to may not have enough time to tell me all the information I need. So we really communicate, very importantly, through notes. All right. I read my colleagues' notes. And if I have a question about them, I may email them, call them, contact them somehow. So really, if you have all your information in one place, accessible for your physicians, and for not just your physicians, anyone who's involved in your care, and it's well organized, it makes a big difference. I can tell you that. And it doesn't matter what country you're in. Okay, you know, I can't tell you how many times I've had patients come in and they don't even know the name of their medicines. They'll say, it's in my record, it's in the computer. You know, well, what happens when the computer ain't working? Or this one system isn't talking to the other system and blah, blah, blah. So part of that is being involved in that care, being an advocate in your care, making sure hears my information, really being educated upon what's going on with you, and which you all are because you're here. But going specifically, very important, primary care doctor, your endocrinologist, rheumatologist, neurosurgeons, physiatrists, or physical medicine rehabilitation. I think here they're referred to as rehabilitation and physical medicine physicians. Is that correct? Here in Canada? I've heard different titles for them. Now, these may not be the same as your pain management doctors. In the States, we have anesthesiologists, neurologists, or physiatrists can subspecialize in pain medicine, okay? Again, psychologists, psychiatrists, neurologists, your rehab specialists, such as your physiotherapist or physical therapist, occupational therapist, rec therapist, there's many types. And a lot of times, if you're engaged in a public health program, you're a public health nurse as well. And them being on the same page, because sometimes they'll see what you can't, and we can nip things in the bud. Very important. So with that international study of pain, they devised what they call the fan of treatment. So basically, this is kind of a stepwise approach. It's also recommended by the World Health Organization on how to treat basically any type of pain problem. Now remember, my Academy of Rheumatology said, hey, we can treat these problems just like any of these other problems, which is helpful because then that means I have a whole arsenal of things we can do. And we're going to go through these specifically, okay? So they're meant to start from the left and work towards the right. Now, I will tell you, you don't have to go specifically in this order, all right? Every person is individual. So we look to see how we can use a combination of these to treat the combination of issues going on. That's very important. You know, I mentioned headaches, but you could also be having back pain and carpal tunnel and foot pain. Well, you don't treat one at the sake of the others. You got to kind of work with them. So they usually recommend, like I said, you start off with over-the-counters and anti-inflammatories. I don't particularly agree with this. Okay, I'm just presenting it because this is what the literature says. Why? I've had many patients self-treat with ibuprofen, come in, and they have a peptic ulcer. Well, the bottle says I can take up to 8. Well, what's 12? I've had patients acetaminophen do the same thing, which is Tylenol for us, and they just didn't know it, but they didn't have the healthiest livers. And next thing you know, they're dealing with other issues. To me, and a lot of times people will stay here for years. Oh, I'll just keep doing this because this is what's working for me. I went online and I went in this chat room and they told me this combination works good. I had a gentleman who came in because he was suffering from horrible headaches. And he read online about snorting Tylenol. Honest to God. And he wasn't a drug user. He wasn't a drug user. He wasn't the most educated gentleman, okay? He was very impoverished, okay, and didn't have a lot of money, and just wasn't very well educated. But he went online, and he did it, and it helped his headache for about 4 or 5 hours. And then it came back worse, so what did he do? Take a pill, open the capsule, crush it, and snort it again. And he had done this for 6 months. When he finally went to his primary care doctor, the primary care doctor, for some reason, said, go see Dr. Rigueras. And the doctor calls me and says, listen, I have this really sick patient. I need you to see. Can you squeeze him in? I'm like, okay, sure. Tell him to come over. He did. Not real nice guy. I mean, his wife was with him, extremely concerned. We had a very lengthy conversation. I did drug testing on him immediately because I wanted to see what else was I doing. Clean. And I asked him, why are you doing this? Well, I started off, I read it on the internet, and it worked, but it just wears off too soon. And when I looked at him, oh my God, when I looked inside his mouth and in his nostrils, I don't want to discuss you guys, but this was horrible. I mean, there was a huge amount of fungus in there. The skin had completely eroded. I could see bone. So I immediately called a friend of mine who's an infectious disease doctor and another friend of mine who's an ENT, a rhinologist, and had them see him. And, well, they put him in the hospital that same evening, did tons of surgery. And so the internet, chat rooms, not necessarily a good place for information. I always tell people, and I'm kind of blunt about things, I said, listen, your Google search does not equate my medical degree. So this is why I don't necessarily agree with this, okay? But if you have a headache, that doesn't mean run to the doctor, right? Or back pain, yeah, you can use some of this. But I usually tell people, if the problem is lasting more than a week, you gotta go in and see your doc. All right, so standard of treatment, okay? This is usually, a lot of times they'll say, take some aspirin, take some ibuprofen, take some of this, and then if it doesn't get better, call me. Typically your first line agents, like I mentioned. A lot of times if you go see your physician, now, again, I apologize, some of these names here you may not recognize, okay? But they may give you some medicines like an anti-inflammatory, a prescription dose, okay? With specific instructions, like naproxen or naproxen. They'll say, hey, 500 milligrams, I want you to take it twice a day with food for about 2 weeks, and then I want to see you back. Now you have some follow-up, you have some direction. A lot of people ask me about natural. There is no such thing as natural. Everything comes from nature. Whether it's in a laboratory or from a plant, there are a lot of plant substances that can kill you. It's called poisons. Okay? A lot of natural supplements can interfere with your medications. Just because it's natural doesn't mean it's better for you. There are a lot of natural substances that work really well. I have patients who have severe kidney problems. They have allergies to NSAIDs. So I said, how about some arnica cream? Bless you, by the way. And to the slide? No. I tell them, here's some liniment cream or some arnica cream. And it works well for them. Okay? But you got to be careful. Again, the internet gives a lot of information. The problem is knowing how to sort it out. So here, I've told patients, well, we can try some turmeric root. I have a lot of comorbidities. I have a lot of patients with fibromyalgia and polymyalgia rheumatica and all these diseases, and they're tired of taking other medications and they want to try these. There are options, but you got to be careful with them. Physical therapy, TENS units. A lot of people will say, I went to therapy and it didn't work. It made it worse. My question to them is, well, what information was given to the physiotherapist or physical therapist? They go, what do you mean? How did your doctor communicate with them? Did he give them a prescription and say, yep, do some physical therapy for a few weeks and let's see how you do? Well, yeah, it's not going to work. That physiotherapist isn't diagnosing you with all the problems. They need specific direction. This is where having those records and having a clear communication of expectations with that therapist from your physician could really help. A lot of times also, it's for very specific issues. If you just say, I'm going for it because my back hurts, well, what's causing your low back pain? Oh, the MRI said an L5 disc. So they just put you on a decompression table, and next thing you know, you're like, I feel worse, because the issue that was causing the symptoms weren't that disc. So therapy helps a lot, but it has to be used like anything else at the appropriate time and correctly as a tool. It's another tool of use, okay? Very important. TENS units, a lot of times I like because it gives people the ability to treat themselves. I'm just gonna pick on back pain now. They can put it on, they're at home, they can use it. The worst case is if it arcs, you feel a little zap. You've either sweated too much, the little pads are come off, time to change the pads. But it gives you a lot of ability. People always say, well, it stops working when I take it off. Yes. But the nice thing is you can go off and work with it. A lot of times when you read the labels, they say, well, you're not supposed to drive, you're not supposed to sleep with it. Well, the company needs to say that to you. I've had patients who work at GM factories, and this is what gets them through the day. I have a couple patients who are surgeons, and they actually have these on them when they're doing surgery. Of course, they have them taped because they can't afford an arc, right? That'd be bad. But it helps them. It really does. Yeah. Chiropractors, osteopathic manipulative medicine, another form of treatment. Again, none of these treatments by themselves, do the whole trick. It's a conglomeration of these things. Can help a lot. Massage therapy can help a lot, especially for those shoulder pains, between the shoulder pains, especially women who get those a lot, right? And some men too, can help a lot. And we already talked about the TENS unit. Other forms of treatment that can go in conjunction with what you're having. Acupuncture. Amazing studies. on acupuncture. We know that the general response rate for the general populations in North America are about 43%. Now, that's in general, but when you go down to very specific problems, those success rates can go a lot higher, okay? I've seen success rates as high as 70-some%, which is pretty good for medical treatment. Now, I'm going to apologize because I just saw my time, so we're going to speed up a little bit more if that's okay with you guys. Sorry. So complementary medicine is also known as integrative medicine, okay? So this is using form of treatment like meditation and integrating yoga, and sometimes they'll talk about integrating Reiki and all these other forms of treatment as well. Tai Chi, biofeedback, cognitive behavioral therapy. Now, a lot of times, remember I said it's mixed pain, nerves? Well, we'll use a combination of different medications because besides all these other things, we do have medications we could use. You know, if we know there is some depression, we know that there's that nerve component, we know that there's tight muscles, we can use a combination, maybe a little bit of duloxetine with a little bit of gabapentin combined, with possibly a non-sedative, well, depending on your sleep patterns, right? Because we talked about obstructive sleep apnea. We may want to use a muscle relaxer that could help reestablish your normal sleep architecture. And there's ways to do that. Maybe some compounded medications that can help a lot. So a combination, and notice I haven't mentioned opioids. Okay? So a combination of these tailored to the person, but you got to titrate them. Injections, pain shots. Very, very helpful if you're diagnosed correctly. People think pain shots are an epidural. Epidural trigger point. I can tell you there are hundreds and hundreds of procedures that can be done for pain. Many of them just in the back. But you first have to diagnose the problem. There's a huge difference when I'm talking to patients, examining them, and they have this disc on the MRI, and they keep talking to me about that. And really the problem is something called your facet joints, or SI joints, which in the Acromegaly Society and population, huge. Why? Because we know that it's a synovial joint that's susceptible to deformation from that disease. Well, we can treat that without ever doing an epidural, regardless of what that MRI said. And we can test it in real time. So the biggest thing about when it comes to injections is you have to have a thorough physical exam, thorough history taking, in combination with some of these other diagnostic tools to really figure out the different things that are wrong with you. And these injections shouldn't just be used initially as treatment. They should be used initially as a form of diagnosis. If I hurt here and I put some medicine right here, and my pain in 20 minutes gets significantly better, wherever the tip of my needle was at was the cause of my pain. It's that simple. Sorry, I'm skipping some of these because we kind of touched upon them. So one thing I do want to stop and mention is platelet-rich plasma injections. There's a lot of stuff in the news on it. A lot of pro athletes will go many different places to get these type of procedures. This is very helpful. Okay, there's no side effects to it, except you have to be selected. You have to have the right criteria. Someone who doesn't have cancer, someone who doesn't have an active infection, and there's certain medications you kind of want to avoid being in here at certain times. So this is basically where we take some of your blood, spin it down, extract certain platelets out of it, put it in the plasma, and re-inject it in a joint or a ligament. And what it does is it can call your stem cells to that area and help repair some of this damage. It doesn't make it like new, but it can help, and I've had great success with these. But again, they're not for everyone. It's very tailored to the person. Now, corrective surgery. I always put the slide here because people think of the term fix. Doc, can I have some surgery and just, it'll fix it? You're not a car. If I change the alternator in the car is fixed. We all have scars on our skin from when we're little kids, from running, falling, cuts, right? Yet, let's say we're 70 years old. That scar is still there. Why? I mean, the thickness of your skin has completely changed itself, right? It's replaced itself, but yet the scar remains because the body never forgets an injury. Unlike a car where you switch the alternator, the car doesn't remember the previous alternator, right? Well, I think my car does because when the alternator goes, the starter goes, the battery, the transmission. But anyways, but our body doesn't. Okay? So we don't really fix the body. We help it heal itself. It sounds like I'm splitting hairs, but I'm not. Because it's like when you sprained your ankle. You know that's your bum ankle, and you got to be careful with it sometimes. Yet, that was 20 years ago. Same thing. The body lays down scar. Scar isn't the same type of tissue as skin or whatever else. Whenever something gets injured, it puts down a scar. That scar doesn't work the same. Okay, so remember that. So when you say corrective surgery, be careful. You're really talking about trying to set the body up in a condition that allows it to heal itself. Okay, but you're not fixing it like you would a car. Opioids, very important. First of all, people say, if I take hydrocodone, I get addicted. No. Addiction, when you look at misuse, abuse, addiction, these definitions are very specific, and most of them have psychiatric implications. Okay? You can become very quickly dependent on this, just like a diabetic would become dependent on insulin. But addiction is different. Addiction isn't the fact that you need this medication to function. Addiction is you desire this medication for effects other than to properly function, to properly address the issue. You're using it for reasons other than its intended purpose, and it has an overdriving effect on your behavior that's irrational to its treatment. That's very important to understand. Okay? So people say, if I take an opioid, I'm going to get addicted. I don't want it. There are certain personalities that are very prone to addiction. And they should be, before giving these medicines, you need to look for these red flags to try to avoid it. Because the same way they can be addicted to this, they'll be addicted to green Jell-O. I had a patient who was addicted to green Jell-O. So it's very important. These medicines should be very closely monitored. These aren't like your regular medications. You shouldn't really be getting refills on any of these. The person who's managing this should really be having regular conversations with you, really tailoring how much you're getting, monitoring it, checking your urines, checking your labs, doing random pill counts, random urine screens to keep you safe. Okay? And it's not just, I need more, let me take more. No. Because you can build tolerance to this. And there should be a very clear-cut, common-sense way to how to use this. There's two types of opioids, short-acting and long-acting. So we'll start off with long-acting then. Sorry, this thing is going backwards. Okay. So long-acting are medications that are extended release. You take one, and the treatment effects from it can last 12 hours, 24 hours. Okay? You don't get a high from it. It just basically reduces that pain level. Very important. Why? Because this is like your baseline. So if your pain usually runs around a 7, this will help bring it down to a 4. And your brain doesn't really care if you're in pain or not, by the way. Your brain only cares the change in pain, right? If you wake up at a 4, 2 hours later you're at an 8, and then you're at a 6, that's what your brain cares about. If you're always at an 8, it becomes kind of like white noise. So it's the change in pain that your brain cares about, what we call the amplitude. So if we can drop that down and kind of keep it at a stable level, that becomes far more tolerable. It allows you to function better. That's what the use of this medicine is. But you can also have breakthrough pain. Let's say you're washing the dishes and little Johnny stuck his gum to the dish and you're really rubbing it, you know, more so than what you usually do, and it's causing you more pain. Or weather systems came through and you all realize how the weather affects pain. Grandma was right. And these bad storms can all of a sudden roll in, and all of a sudden you realize this. You can have breakthrough pain. That's where the short-acting medications, they work for about anywhere from 4 to 6 hours. They give you a very quick, immediate response, usually within half an hour. And they try to bring your pain back down to baseline. Realize, at no point did I ever say, take your pain away, right? It's not a painkiller. Doesn't exist. Anesthesia is your painkiller. And you don't want to be intubated and sedated for the rest of your life, right? These are to help manage pain. They don't kill pain. They're meant to be appropriately used to help you function. Very important. But again, you have to be very closely monitored when using it. And you don't use these by themselves. A lot of times, and this is not where you start. You start with all the other things we mentioned. And if at one point you have to integrate these, then you integrate them, but for the goal of maintaining your function and quality of life. Now, there are ways to test this. Okay? There is a pharmacologic type testing where we can look at some of the enzymes in your liver and how they process. these type of medications. And it can give us some indication of what type of medicines you would process well, okay? So it's a mouth swab, and we send it to a lab, and they check these enzymes, the P450 enzymes in your liver. And it tells me if you're a fast metabolizer, a rapid metabolizer, if you're a poor metabolizer. And what that means is how you process these type of medications. Does it hold absolutely true? No. I've had patients who these tests come back and say, this is the perfect medicine for you. You shouldn't have any side effects. And when you give them that medication, they're coming back with diarrhea and nausea. But they have helped to figure out the right combination of medications for patients. So this type of testing does help, but it's not 100% either. Neuroablation. So remember I mentioned that example of the low back pain where the MRI showed a big disc, but I said it's this joint in the back called the facet joint, let's just say. And these tiny little joints that run up and down the spine. Very, 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 very common, especially in acromegaly, for a cause of back pain. There's a little nerve that goes to those joints. This is a technique where we can first test to see if those joints are the problem. In the office, sometimes surgery centers, or in the hospital, they put some numbing medicine over the nerve that go to those joints. And all of a sudden, if within 10, 15 minutes, your pain significantly drops, we've proven that's the source of your pain, or at least of that particular complaint. And at that point, we can then decide if we can actually heat up that nerve a little bit. Now, when you read about this, it says burning. We're not really burning. You're not coming out like extra crispy. We heat up the nerve. And what that does is it decreases the ability of that nerve to transmit pain from that joint to your brain. Notice I didn't say kill. You can still feel pain. If you try to become a gymnast, you'll realize it ain't going to happen. Okay? So it is a very useful tool to have as well. It can be very helpful. It can be helpful, especially in headaches. A lot of times there's this little nerve in the back of the skull called the occipital nerve, which is that one headache that starts back here and shoots forward. Sometimes it can catch your eye, that then all of a sudden provokes your migraine. We can actually do that to this nerve. There's a lot of, so this technique can be very helpful, okay? You'll hear about intrathecal therapy. I don't do this. I think it's very problematic. You need a lot of follow-up. You're constantly getting poked on it. A lot of people still use it, especially people who have very, very large doses of medications. I think it's, in my opinion, I don't endorse it. I teach my fellows how to do it, but it's not it's like last straw. And usually I use it for my patients who have severe spinal cord injury, which is not the case here. Neural stimulation. Now this I have found incredibly helpful. Neural stimulation is a spinal cord stimulator. And what it is something that doesn't use medications. You don't have to get repeatedly poked for it. It can be reversed if need be. And you get to know exactly how it's going to work before you commit to it. Okay? So what it is a little device. Looks like a little pacemaker for the back is what I tell people, or an internal TENS unit. So during a trial, you go into the office or surgery center or hospital, and they figure out, based upon your pain patterns, where in your back, on your spine, we can catch all the little wires that go to your brain, and then we can interfere with that pain signal. And we implant these two little leads. Let me see if I have a picture of it right here. So here's that little pacemaker thing. There's these two little wires, and it's all reversible. I mean, this is done through two needles. We implant it, and then once we put it in place, right there on the table, we ask you, are you feeling tingling? Are you feeling sensations where you normally have your pain? If you say no, we keep moving around, and you really don't feel much of that, until you say, yeah, I feel that tingling. I feel it in my legs where it hurts, in my lower back. I feel it in my ribs where some people who have bad shingles have it, and what have you. We can really tailor this specifically to where the problem is. And once we do that, we tape it down, suture it, and you go home for about 5 to 7 days. At which point you come back and we take it out and we ask you, how well did it work? And normally I ask my patients if, and like I said, I'm pretty blunt with them. I said, if I said this didn't work and I'm not going to approve you to have it permanently put in, how pissed would you be? And if they tell me I'm about to hit you, I'm like, you're approved. If they're like, I'm not sure, then I know it didn't really work. And we don't have to pursue that further. It's one of the few things you get to test and know how you're going to respond. Now, sometimes a year out, 2 years out, people feel it differently than the trial. But most of the time, it's because this thing, what I love about this thing is it can be consistently reprogrammed. What do I mean by that? So let's use this one. Let's say all of a sudden your back pain, your leg pain is gone, but you're really feeling middle back pain. All of a sudden, the people from that company, whichever companies, there's about 3 major companies that do this, will meet you, usually your doctor's office, sit down with a little computer, put this little reader on your skin, and they change the programming. And you have a remote control with this thing as well. And you have control if you want to increase it, decrease the sensation, change where the location of the sensations are. So as you get older, this can allow you the opportunity to have some control over that pain without getting repeatedly poked, not consistently looking at possibly getting more MRIs, more surgery. It can definitely help reduce the use of your medication. And it gives you control. You can shut it off if you want to. The drawback to it is you got to recharge it. Now, there's some that are non-rechargeable. I don't like those because the battery I only use them in my very elderly patients who are a little demented because it's, they forget to charge it and what have you. But you got to recharge it. How often? Everyone's different. It depends on your use. But this thing can be changed. The programming can be changed every day if needed be to kind of move it around. Now, if you implant this in the middle back, it's only going to help your middle back down. If you implant it in the neck, it's going to usually just help your upper half. But there's a lot of literature and a lot of studies looking at this. So this is something that I'm always excited about. I've done probably over 1,000 cases of these already. And we have a very high success rate with it. So something to also keep in mind as a potential tool in your arsenal, okay? So that's the end of it. I think I came right under the wire. So I apologize if I skipped a lot and if I went a little too fast. But my main points I wanted you to take from this is what exactly is pain. 2, there's definitely a lot of guidelines for treating it. There are lots of tools, and these tools can be used simultaneously. And you really should be using you should really put together a treatment team to help you with these things. Okay? Thank you so much.